Let me start with a moment that happens almost every day in the clinic. A patient walks in with a blood report. They sit down, they look tense, and they say, "My cholesterol is high. My doctor told me I will need medicines for life. They said my heart attack risk is very high." Now pause. Before we react, before we suppress, before we panic, we need to understand one thing clearly. Cholesterol is not a disease. It is a biological molecule, and treating a molecule without understanding its context is how modern medicine quietly creates fear instead of clarity. Cholesterol is a structural and functional molecule. You need cholesterol for every cell membrane in your body, for brain tissue and myelin insulation, for all steroid hormones, for vitamin D synthesis, and for bile acid production for digestion. About 75 to 80% of cholesterol is synthesized by your own liver. Only a small fraction comes from food. That single fact already destroys the idea that cholesterol is simply a dietary villain. The body does not manufacture toxins in bulk. It manufactures adaptation tools. Now let's clean up one of the biggest confusions. LDL and HDL are not cholesterol. They are lipoproteins. They are transport vehicles. LDL carries cholesterol from the liver to tissues. HDL carries cholesterol back to the liver for recycling. LDL is not inherently bad. HDL is not magically good. LDL becomes problematic only when it is damaged, oxidized, and trapped in an inflamed vascular environment. This is a key concept doctors understand, but patients are rarely told. Inflammation comes first. Cholesterol follows. Cholesterol shows up at damaged vessel walls because it is part of the repair process. Now let's slow this down and decode a lipid report the right way. Most people look at total cholesterol first. This is the least useful number. A wise interpretation starts elsewhere. First, look at triglycerides. Triglycerides tell you how well your body handles energy. High triglycerides often mean insulin resistance, poor fat metabolism, excess refined carbohydrates, fatty liver, and inflammatory overload. Triglycerides are not structural. They are energy storage molecules. When they remain high in blood, it means energy is stuck and not being cleared. This is metabolic congestion. Second, look at HDL. HDL reflects metabolic health, exercise capacity, and insulin sensitivity. Low HDL is a warning sign, not because HDL is protective by itself, but because it reflects broken metabolism. Third, calculate the triglyceride to HDL ratio. This ratio is gold. Triglycerides divided by HDL. Above 3 suggests insulin resistance. Below 2 is generally reassuring. This single ratio predicts cardiovascular risk better than total cholesterol in many populations. Now let's talk about the marker that actually creates havoc. Triglycerides. When triglycerides stay elevated, LDL particles become small and dense. Small, dense LDL penetrates vessel walls more easily. Oxidation increases, inflammation accelerates. This is not opinion. This is lipid physiology. This is why many people with normal cholesterol still suffer heart attacks, and many with high cholesterol do not. Because cholesterol is not the fire. Triglycerides plus inflammation are. Now we address the sensitive topic, statins. Statins inhibit HMG-CoA reductase, reducing endogenous cholesterol synthesis. They are life-saving in secondary prevention, post-myocardial infarction, and high-risk vascular disease. This is non-negotiable. But here is where misuse happens. Statins are often prescribed in low-risk primary prevention without correcting insulin resistance, high triglycerides, fatty liver, micronutrient deficiencies, and inflammatory load. Statins lower cholesterol numbers. They do not fix metabolic dysfunction, and they may deplete CoQ10, affecting mitochondrial energy production. This explains muscle pain, fatigue, and weakness in some patients. Statins are tools. They are not substitutes for metabolic repair. Now let's connect what is usually separated. Vitamin D influences insulin sensitivity, inflammation, lipid metabolism, and endothelial health. Low vitamin D correlates with higher triglycerides and worse metabolic profiles. Magnesium is required for glucose metabolism, insulin signaling, and lipid enzyme function. Deficiency worsens triglycerides and insulin resistance. And then there is liver health. The liver controls cholesterol synthesis, triglyceride clearance, and bile production. Fatty liver is not a liver problem. it is a metabolic traffic jam. And treating cholesterol without addressing liver health is incomplete medicine. Now let's address common myths directly. High cholesterol means heart disease? False. Context matters. Inflammation and triglycerides matter more. Lower cholesterol is always better? False. Extremely low cholesterol is associated with hormonal imbalance, neurological issues, and increased mortality in some populations. Statins fix cardiovascular risk? Partially true. They reduce risk only when used appropriately. They do not replace lifestyle, nutrition, or metabolic repair. A wise clinician asks, is this patient inflamed? Is insulin resistance present? Are triglycerides elevated? Is liver function compromised? Is vitamin D signaling adequate? Is magnesium sufficient? Only then do we decide lifestyle intervention alone, nutritional correction, short-term statin use, long-term statin use, or no statin at all. This is not alternative medicine. This is precision medicine. Cholesterol is not the villain. Triglycerides are the warning. Inflammation is the driver. Statins are tools. Blood reports are not verdicts. They are maps. Perspectives can be different, but biochemistry cannot be wrong.